Good morning, good afternoon, everybody. Thank you, everybody, for joining our roundtable discussion today. We will be discussing a recent white paper from myself, Stephen Towe, the CEO of Leo Cancer Care, the chairman of Leo Cancer Care, Mackie, and the president of Proton Therapy, Niek Schreuder. The title of that white paper that we'll be discussing today Is Upright Radiotherapy Medically and Financially Better? So we are going to present a few slides just talking about the highlights of that white paper before opening up a discussion with our scientific advisory board and just discussing in general the findings of that paper. So again, thank you everybody for joining us. Please feel free to leave any questions as we go, and we can get to those questions at the end. And yeah, we'll discuss those after we've gone through the slides. So first of all, just the people involved here. So myself, as I said, Stephen Towe, the CEO of Leo Cancer Care, Mackie, and Niek Schreuder. And Rock, I'll hand over to you to give a little bit of an introduction to the advisory board members that we've got today.
Thanks, Stephen. We have Jay Flanz, who is a recently retired. Oh, can you not hear me?
Yes.
Okay. Oh, you're sorry, Jay. You put your thumbs up.
Say hi.
He's the recently retired technical director of the Department of Radiation Oncology at the Massachusetts General Hospital, and he is a Harvard University professor. We have Jim Welsh. Jim I've known for a long time. He was at the UW at the dawn of tomotherapy, and in fact, the first patients were Jim's patients on tomotherapy. He's the chief of radiation oncology at the Hines VA hospital in Chicago, and he's a physician at the Northwest Proton Center in Chicago. We have Lawrence Court. Lawrence is an associate professor at the MD Anderson Hospital in Cancer Center in Houston, and he is really one of the persons that have launched upright radiation therapy with a research study that he started a number of years ago. Mark Pancook is the director of medical physics at the Northwest Proton Center in Chicago. And in fact, Mark treats many of his upright lung cancer patients on an upright system. And I believe that's who we have today on the advisory panel.
Thank you very much, Rock. So let's start talking about the white paper in question and talk through some of the highlights of that paper. So one of the questions that was really addressed, and we still get fairly frequently when we talk to people about upright radiation therapy, is really, can patients be set up in the upright orientation? Can they be done so reproducibly? And the key point to this, as we discussed very briefly in the paper, is that immobilization devices really are a secondary step when it comes to reproducible setup. You have to start the discussion here and start the idea of reproducible setup with the idea of having a stable core position. The immobilization really is then the secondary element. And the design of the patient positioning system from Leo Cancer Care does exactly that. The core design, really the whole aim is to get the core position of the patient stable. And we do that, especially in our perched position here, by having support and applying a force on the patient in multiple different directions. So we stop the shins slouching forward by using a shin rest. We then support the heels of the patient and drive the heels forward using a heel rest. And then we support the mass of the patient behind the backs of their legs and behind their back using the seat pan and the backrest. And the key thing there with the backrest is that it's never really perfectly upright. By having just a small tilt either forwards or backwards, you can use gravity to give you a much more stable core position. And then step two there really is, how do we deal with the immobilization? How do we add to that core position to really make sure that the patient is stable? And we summarized some work that was done at the University of Surrey in collaboration with the university, also with the Royal Surrey Hospital, with CIVCO, and with the National Physical Laboratory in London, where we put a very early prototype. We used existing immobilization devices, but adapted them for upright patient positioning. And we rotated patients round at treatment speed at 1 RPM. And then we asked them to get out of the immobilization devices and out of the patient positioning device and repeat that setup. And the devices that we were using, as I mentioned, were really the devices that we're using in the clinic today. So things like vac-lock bags, thermoplastic masks, and abdominal restraints, everything that we're commonly using in the clinic today. And as I said, this process for this experiment was really set up the patient positioning device. So get it into the right position, get the vac-lock bags on, get the patient into position, add the secondary immobilization devices like the thermoplastics, acquire an optical image of marker positions of various different locations on the patient, and then repeat this, this process with the same volunteer and then with multiple volunteers. What we can see here and what is summarized within the white paper was the results of that experiment. And you can see here the data from our experiments in the dots. So in the blue dots here for left, right on the patient, the black dots here for anterior, posterior in the patient, and the orange dots here for inferior, superior in the patient. And they are superimposed on data that came from an early study of a clinical system, a clinical tomotherapy system that did almost the same thing. So set up patients and monitored their reproducibility. And again, with all of these data, it's all applied just after the pre-treatment imaging, but before the adjustment is made. And what you can see here is really the answer to that question. Can we set up patients reproducibly in the upright orientation, even with a very, very early prototype? And this work will be repeated. But I think the conclusion that we make from this data is, in fact, with a stable core position and adequate immobilization devices, there's absolutely no problem with reproducibility in the upright orientation. So Rock, I'm going to hand over to you to talk through the clinical data that we presented in that paper.
Okay, thank you, Steve. And some of the data that we presented in the paper was really just referring to publications. Next slide, Steve. And so the indications really are that in lung, there's less lung movement because the lung generally is more inflated in the upright position. And the reason for that is that the diaphragm is pulling the lung down. And this, of course, helps with breathing for the patient as well. Some recent work that I'll talk about from PSI showed that there's a liver drift that lasts tens of minutes when you transition a patient from upright to supine that you can avoid if you're treating them upright. There's less issue with bladder filling, and that's work that we've done, and I'll talk in some detail about that. And then there's just some physical and psychological comfort differences in being upright. We spend most of our time upright. We feel more psychologically confident in the upright position, but it's easier to swallow, and there's less gastric reflux issues, so no danger of breathing in liquids into the lung. Next slide, Steve. So you can see here, this is work from the Lawrence Court group that shows a patient. So there's a big difference between the upright and supine position. You can tell that it's less dense. Next slide. And so this is some 5 patients. The average increase in volume was about 25%. But you can see it's highly variable. Next slide. what this means, and also the same paper from Lawrence's group, was that there's about a 4 millimeter reduction that is typical. And then we know that the average displacement in lungs in the supine position is about 9 millimeters, 9 or 10 millimeters. And then it's been recommended that if you can get a patient down to 5 millimeters or less in terms of motion, then motion management issues like gating is not really necessary. And so we think that we're going to have a lot of patients that transition from needing gating to not needing gating. Next slide. And this work was also done by a recent paper, and this is from a paper by Yamada, who have a Canon CT scanner in the straight vertical position, and they typically use it for standing patients, and they show a smaller change in volume on the order of about 10%. Next slide. This is the interesting work from the Paul Scheer Institute by Tony Lomax's group that showed that when you lie a patient down who is getting a liver treatment, then there's a drift, a slow drift that takes tens of minutes to stop. And what's going on is that the liver has an interesting cellular structure that is lamina of cells that are around a vascular system. And so this is acts like a very, if you like, thick liquid that takes a long time to be repositioned by gravity. And in fact, it takes 35 minutes to stop. So one has to wonder how often we've been treating the liver, thinking that we've got the patient set up correctly, and haven't checked at the end of the treatment to see if in fact the liver was in the same volume. So next slide. And this isn't a small shift. This is often on the order of 10 millimeters and up to 20 millimeters. And so I really do think that, and this is a systematic error. It's not motion like the lung, where sometimes it's in the field and sometimes it's not. This is moving out of the field. Next slide. This is some work that we've done. In fact, two of the volunteers I know are on the phone for this. We did a test of MR scanning, the Phonar, and in fact, 2 other vendors have MR machines that can image in both the recumbent and upright positions. And on the left, you see a full bladder in the supine position. And on the right, you see a full bladder in the upright position. And one of the things that's interesting is that the abdominal contents are really pinning the prostate in place. And oops, I see that the contour lines have moved for some reason on that image of the bladder. But go to the next slide, Steve. Here we see them together. Both the supine and the upright. This slide is showing the full versus empty bladder in the upright position, and you see that the prostate with different amounts of bladder filling is not moving. And this is important because we often in recumbent positions, in the supine position predominantly, want the patient to have a full bladder so that we're pinning the prostate in a constant space, a constant place. And we know that in supine positioning, that if we don't have a full bladder, the prostate position will move. And here you basically see in the only 2 volunteers we've done so far that's not the case. We hope once COVID is over to do a multi-patient study to see if this trend continues. Next. Okay, Niek, you're up for the economic aspects.
Great, thanks, Rock and Stephen. So let's go to the first slide, and Stephen, you can just click 3 times here on this slide. The entire thing that probably was missed in the past for upright is the increased workflow. And workflow, of course, is extremely important. And so the first thing here I want to address is just we have so much easier ingress and egress for the patient getting into position. And you can see on that picture there is look at the enormous amount of space around the ISO center to get the patient in and out. The second aspect is really improved image guidance. I just want to make that very clear that every time we talk about upright positioning, we are talking also about a significant enhancement in the image guidance. So the dual energy CT will be the first time that I at least know that we'll be able to do dual energy CT at ISO center. We'll be able to add the proton radiography, proton CT, prompt PET, prompt gamma, and optical tracking to the mix. And next click, Stephen. That will then allow us to treat with more accuracy, smaller margins, eventually do what I call progressive plan adaptation. And it's all based on more access to the patient, more ability to install new things that will allow us to go much faster. Next slide. One thing that's often neglected, and Stephen, if you can click 2 more times, we know that the patient positioning process takes by far the bulk of the time of treating a patient. But if you look clearly about how external beam radiation therapy works, then there's really no difference between X-rays and protons and carbon ions. But up to now, there was vast amount of difference in how we set the patient up. And I think what we are up to here, if we go into the upright paradigm, then we can actually start standardizing radiation therapy across, the patient positioning component at least. And I think once we start standardizing, we'll see a tremendous amount of cost savings in that process. Next slide. So here we have a little cartoon, and if you can click 2 more times, Steve, then we'll see that the process involves, if you treat a patient lying down, first you have to take the patient seated on the table, and then 2 therapists have to lay the patient down, while on the other side, the patient just walks in and sits down, and that is the first step towards treating the patient. And of course, you have to lay the patient down and put the immobilization device on. So now next slide. And if again, you can, so now the beam comes on, and click again the video, Stephen, thanks. Now we have to, treatment is done. Now we have to first remove the immobilization, and we need to sit the patient up before the patient is ready to exit the beam. So 2 more clicks there, Stephen. That just is, well, yeah. It just means there's also more steps to getting the patient out of the room. And next slide. If you now look at this slide, where I took just a single beam treatment, and I just based on those 2 aspects, making the patient comfortable on the couch and getting the patient out of the treatment room, you can save an enormous amount of time. If you do this math on this stage, then we can easily look at a 6-minute saving just between treating supine and upright. And that was actually 100% confirmed with a paper from Japan that Rock was mentioning. They found that imaging a patient for just normal CT scanning in upright position, they found take half the time than imaging the patient lying down. And that's the very same reason. So we believe when it comes to cost, go faster, get more patients in a certain time will have a huge cost driver. Next slide. Now the size, of course, is very apparent here, and what we see here on the left here is a 2 gantry system, and the right is a 1 gantry plus 1 upright system. We can see the vast reduction in size, which then automatically leads to a significant reduction in equipment cost and also the building cost. We know that at least in the particle therapy space, the equipment was not really the problem. It's the total project cost and the total size of the building. Next slide. So if we look at the shielded volume, these particle beams, and it's of course also very relevant to heavier ions, but also relevant to photons. And if we just look at the inside dimension of the shielded volume between a typical room temperature gantry and the upright space you need for upright treatments, that ratio is about 16 times smaller. The smallest gantry, I'm not talking about the total system, but the smallest gantry that was ever built was the Pronova superconducting gantry, and the ratio there is an order of 10 times, even 10 times smaller than the smallest proton gantry every bolt. In the LINAC space, we'll show that later on. There we can also see a significant reduction in size. Next slide. Now, what we, at this point, is not saying that we do away with gantries, and there's a lot of people nervous about, can I go without a gantry? I'm saying what we have to prove first is that if we go upright and we enhance the imaging, we're doing much, much better imaging, maybe eventually we can do away with gantries. But for now, we would say that the gantries will remain there to be used for the specialty machine. These are young kids that have to lie down, perhaps for anesthesia. We also don't plan to treat below the leg, upper thigh, and you know, maybe a patient that really needs a vertex field. But we believe, and the clinical evidence, as Rock already showed, and a lot of other papers out there show that we do much better in other areas, and that could become the workhorse machine because we will be able to do faster throughput. I personally don't believe any treatments have to take longer than 10 minutes if you do a careful analysis. Next slide. And Stephen, if you can just click through a couple of times here. This just speaks to the fact that now if we do with upright systems, we really always have a problem in protons that once you buy a system, you're locked in with that technology for the next 25 years. But as technology change, we have to go to flash and mini beams and rotation therapy. Really, only thing you need to change in the upright scenario is the beam delivery nozzle. You can click 2 more times, Stephen. And we know the fixed beam nozzle is a really simple device, just scanning magnets and ionization chambers, and that can really be replaced quickly if the technology changes and you need to change your delivery system. So that has a huge cost aspect that you can actually safeguard your technology against future changes. Next slide. So this is just, we're also building a LINAC. The LINAC will be able to, 2 of these upright Ruby machines will actually easily fit into the space of 1 existing LINAC. Next slide. And of course, that will allow us to put these machines eventually much, much easier into a mobile scenario where you have the Marie CT scanner on the one side of the truck and the LINAC on the other side. And then the last slide I want to show you guys is just how easy the upright system would fit in a LINAC room. So here's a proposal. You put the accelerator in one LINAC room and the upright system in another LINAC room. So to summarize then, we'll save costs through efficiencies in throughput, better medicine, better image guidance. We'll open up new disease sites we can treat, and we'll save tremendous amount of cost in space of it. And that's all I have to discuss with you.
Perfect. Thank you, Niek, and thank you, Rock, for talking through those. What we're going to do now is open up to a general discussion with the members of our scientific advisory board that we introduced at the start about really their experiences and what they can take from this white paper. And during that time, what we are going to do is leave the list of references that we used for that white paper up. So you should be able to see those, and we will send those list of references out to everyone that was on this call as well. But let's start by handing it over to the advisory board, and really maybe start with you, Lawrence. Rock presented some of the work that you did down at MD Anderson there, but it'd be great to hear from your perspective a little bit about your experience of doing that work, and also really why that work started. What was the driver behind that work?
So thanks, Stephen. So the initial driver was for our Proton Center, and I was asked to see if we could treat patients, improve the number of patients we were treating with our fixed beam that we have down there. And very quickly, I think, I was pretty skeptical about the whole thing at the very beginning, and through that work, very quickly realized that there was a lot of interest from people on the photon side as well. We started with that lung work that Rock presented, with showing how the lungs are larger and there's less motion. Through that, we got a lot of interest from our thoracic teams. And also the head and neck team got very interested very early on. So, I think our work at least moved to the photon side quicker, mostly because my interest, I think that the photons is more scalable to more people more quickly. But the initial driver was protons. And there's not, I mean, Rock gave me a lot of credit. Thanks, Rock, for the idea. But there's no such thing as a new idea in radiation oncology, I guess. And people, at least as back as far as the 50s, probably further, there's literature on people treating patients in chairs. And so, and there's a lot to be learned about how you use gravity to your benefit to reduce motion and to keep people in the same place. And so either tilting them backwards or tilting them forwards, there's a lot to be learned at. And so we built, our first chair was really essentially a massage chair. It was based off a massage chair, and that was my first experience of sitting in a massage chair. But once you sit in a massage chair, you basically fall asleep, and that, it's very, very comfortable, and you do not move. Once you're there, you're there. You're going to be there until you're done. And so we built this chair based on a massage chair. You have like the pictures that Stephen showed with the knee rests that really help you take advantage of gravity, keep you in the same place. And we also had the body facing forward a little bit, but very successful. We did some intrafraction motion experiments. I think I'm very convinced that this is the way forward for a lot of patients. Like I said, I was skeptical at the start, but through the work, I think it really persuaded me, and especially interacting with the clinical teams and how excited they got about this very quickly.
And what do you think, Lawrence, from the work that you did, the experience you had, what are the kind of, in your mind, the really the best indications, the best areas to be approached in the upright orientation? And what do you think then would be some of the challenges? Which are the trickier indications, do you think, to treat in the upright orientation?
Yeah, so I think we really focused on head and neck and thoracic. And the main reason for those focuses was really that's where we got the most immediate interest from the clinical teams. Thoracic, with the respiratory motion results that Rock mentioned, where you just by sitting upright, you increase lung volume and you reduce motion. So you're sort of getting an easier version of breath hold and maybe abdominal compression. Those things, you're sort of combining some of those advantages without having to do anything very interventionalist. You just by sitting instead of lying, you get those effects. So I think for motion, lung motion, I think it's an easy one. There's also advantages that you don't necessarily think about, at least we hadn't thought about at the start, like where do you put your arms? Like when you treat a patient lying down for thoracic, you typically have your arms above your head, not very comfortable. When you're sitting, your arms can just sort of be rested in front of you. It's much more comfortable for the patient. There was actually quite a lot of interest about that too. So, and then for head and neck, because a lot of, when you talk to patients, they don't, because of the fluid production, they don't lie down when they're at home. They'll sit in the sofa and stay that way. And then they come to the clinic and you lie them down and you lock them to the couch. And so, it's not a great experience. And so just by sitting, you can actually make the experience a lot better. So I think those two sites are where this is going. In terms of where is it more difficult, it's the non-ambulatory patients, which is about 10 to 15% of patients are probably non-ambulatory. And a lot of those you can treat, but I think that's where it's going to get more difficult when patients are not generally sitting up. Okay,
perfect. Yeah, it's interesting. We had a lot of feedback when we were doing the work at Surrey from breast cancer patients that said they find it very difficult to be treated supine with the arms above the head because the shoulder joints are hyperextended. So that's exactly the same feedback that we had, Lawrence, when we started looking at breast treatments. So thank you very much for that. Mark Pancook, you treat a good number of your patients over there at Northwestern in Chicago in the upright orientation. Could you give us a little bit of your feedback and thoughts about your experiences treating upright, and what do you think are the real pros and cons, which indications are best suited to upright?
Sure. Yeah, thanks for the opportunity to talk. One thing I think to talk about our center, we should reference, some of the things that Lawrence just said, is because his motivations were slightly different than ours. We actually have a system with only one gantry, but then some fixed beam lines and then incline beams, which are 90 degrees and 30 degrees from vertical. So really what we were looking for with only a single gantry was and the implementation of pencil beam scanning in our centers, that our gantry just got very, very full, and we were at beyond capacity on that gantry. And so what we needed to do was pull some patients off of that gantry. And one of the sites that we were really looking for was where we saw benefits was lung. And so we did look at Lawrence's work and said, well, there's some potential benefits there. We also were looking at treating brain patients in the seated position with a chair. So what we did is we then moved forward and built and collaborated with an Israeli company to build a seated CT scanner and a chair. And our goal at that point was really to relieve the gantry on lung patients and some brain patients. So the good thing was with the two gantry angles, that even with the patient seated, we were able to get some of the vertex field that Niek talked about. So we didn't even have that limitation. So we did this, got it working. We don't, not every lung patient is treated in the seated position. We actually look for patients where we see a benefit. So some potential lung volume differences. Actually our data doesn't show as much sparing as Lawrence's data. We only see about an average lung volume difference of around like 10% between the seated and supine. But we also, our data is a little skewed because we had some prone, we look at prone patients also sometimes, and the prone volumes get actually skew it because when the arms are up in the prone position, the lungs open up nicely also. So we use it for lung patients. We've, I think our latest numbers I was just looking at, I think we've imaged about 50 patients for the thorax, and we've treated about half of those in the seated position. And we've treated a lot of brain patients. Those work really well. The patients do really great. So now one question would be, why not head and neck? That's actually right in the middle of those. And actually, it's a technical problem on our side. We have a limit in the vertical position of our couch, and so we actually have two separate chairs, one for the head and one for the thorax, and it's based on how much vertical motion we can get on the patient. So unfortunately, we have this cold, like a dead spot right in the middle of the head and neck. So we haven't been able to treat head and necks in that area. But the good thing is right now we're at a nice balance where the head and necks, we are able to treat those onto the gantry. But patients do, like Lawrence said, the patients do enjoy the treated in the seated position. In fact, we just last week, a patient that we're treating right now in the seated position, her niece is a physicist, and she works right down the street from our center. So I had her come over, and I was talking with her, showing her everything that we were doing. And I said, hey, just off, kind of on the side note, how's your aunt enjoying the seated position? And she said, well, she was very happy that she could be seated, because she actually, when she lays back, she has trouble coughing, and when she's sitting upright, that doesn't happen. So for her, she was, one is we had to really spare a lot of heart and lung on her. So that's why she was referred to Protons. But then the second thing was that she was very happy that she wouldn't have to lie down more for that. So to answer your question, Stephen, we're really focusing on lung and brain because it's what we need. I see tons of potential in the head and neck. And I really, I think that I really want to compliment you guys on the way you're designing the chair. You're building something that's an all-in-one, which would be really great. I wish we could do that. We kind of had limited flexibility with how we designed what we had, but it certainly works, and it does offer a good option for many patients.
It would be great to hear Jim and Jay talk about their experiences with Upright as well. So maybe Jim first.
Sure. Thanks, Rock. Thanks everybody for having me participate in the meeting today. My experience with upright treatment dates back to days when I was the neutron beam therapy doctor at Fermilab. And that was a system that was designed and built back in the 1980s. So it was quite primitive in appearance. And that was to its detriment because it did not look like the P-Cure chair that I use today with Dr. Pancook at the Northwestern Proton, Chicago Proton Center, put it that way. Looked more like an electric chair. So it intimidated people, but it worked. It worked very well. And I became a believer, despite some of the prejudices against it. I became a believer because I was using it and seeing the effective results. And I've always wondered, could this design from the 1980s be modernized and adapted for the real world today with all the modern immobilization methodology that we have? Then I started working with Mark at the Proton Center, and like he just explained, we have a P-Cure chair, and I've put several patients in that P-Cure chair. So I've become a strong, staunch supporter for upright radiation therapy. And that is magnified by the fact that at the VA hospital, where I do the majority of my clinical practice, we'll have occasional patients who simply cannot lie on their backs. They absolutely need to be treated in an upright position. It's a huge inconvenience and cost to send such a patient to the Proton Center when they don't really need protons. But if the Proton Center is the only game in town that will treat patients in the upright position now, sometimes we have to do what we have to do. Having said all that, with the modern immobilization methodology out there, specifically when integrated with the stuff that the team here is talking about today, I think that upright radiation therapy is the future. It's here and now, but with this new approach that the Leo team is developing, things can be improved so much further compared to what I use presently and what I've used in the past. And yeah, there's a great unlimited, untapped potential here for treatment of lung cancers, for brain tumors, and in the near future, I think head and neck. I was very impressed to see the prostate motion problem being addressed with upright treatment. So I don't see limitations. All I see are paths forward. And personally, part of my research project is Proton CT. I've always wondered how Proton CT is going to ever evolve into something that could be a clinical reality. It's quite obvious that rotating a patient is going to be a lot simpler and easier to obtain Proton CT than rotating the huge gantry. So for a variety of reasons, I'm, like I said, a very staunch supporter of all of this.
Wonderful, thank you, Jim. Yeah, you've done a huge amount of work for the area of upright. So the thanks should be with you. So Jay, yeah, we'll go to you finally. It'd be great to hear your thoughts about upright and the challenges and pros and cons as you see things. And we have had a couple of questions from the audience, so I'll get to those in just a second, but it'd be great to hear from you, Jay.
Sure. This is a great webinar. I think it's actually a very important topic at a right time. I think Jim said, it's here and now. And maybe one question would be, why is it here and now? And since I'm retired, in some sense, I can talk a bit about history. Maybe not as long a history as Jim or some other people can talk about, but I'll overlap. And there were the pre-gantry times. A lot of people in the field now maybe don't remember that there were the pre-gantry times. And there was a time when Harvard cyclotron was one of the only two places in the country. The other one was Fermilab, as pointed out, that had upright vertical CT scanners, because there was also no such thing as a gantry. people were treating patients in a fixed beam line. And the issues of imaging a patient in the treatment position were too hard to get out of. I mean, there was only those 2 upright CT scanners. Nobody else made something that scanned the patient in a non-supine position. And so that was a constraint. The other constraint was that there was beam delivery modalities. The beam delivery modality was scattering. And scattering requires multiple fields with patching and matching, sometimes very difficult treatment plans involving a lot of difficult patient positioning and getting that patient in the right position. So, you know, that was a time, and in fact, as when gantries were then invented and used, I hear a lot from the original treatment planners those days and the therapist that said, over my dead body will I ever treat patients without a gantry. But then on the photon side, things started happening. IMRT, arc therapy, tomotherapy, no offense, Rock, all began to develop and improve the photon dose distribution. And I think that pushed particles to a new height. And this also further differentiated the difference in the cost between photons and particles or protons, because it wasn't just, oh, well, you're getting a much better dose distribution with protons and therefore you should spend more. The photon dose distribution was also getting better. And then a miracle happened. Scanning was developed. And scanning, of course, was not really a new thing. It was done in the early days with electron beams, but everyone's forgotten about that. But it was developed, and that actually changed things. Most people think that, oh, that just means that it's a more highly conformal dose. And that's what most of the community, I think, sees. But what really is the case with scanning is it's much, much more powerful. It has a higher flexibility in the ability to do beam approaches and patient positionings. It also allows you almost like to go around corners. It's a very powerful thing and changes the whole scope of how you position a patient when you're delivering a particle beam. And the second issue was imaging. It turns out that the technology developed, and it turned out you could build an upright or an angular or an angled or more flexible imaging system. So all these things have sort of changed. And then the question then is, this is a sort of disruptive technology, but it's only disruptive if you can convince people that it is useful. The challenge is convincing that community who suffered in the early days with the scattered beams and the non-very patient-friendly positioners, or the newer people who come into the field and only know gantries. They only know gantries. They've learned on gantries. They've been taught on gantries. They don't know any different. But I think what you have to do is prove it to them. You have to show them. And the data that Steve showed with the new positioning, the data that Rock showed and Lawrence has developed over the years to basically say, no, you know, you have to look in more detail at positioning a patient, what the pros are, what the cons are of different orientations. And with the right imaging and the right patient support, you can get a high quality, higher quality treatment with a scan beam in a particle center, which allows you to reduce the cost, reduce the space, and gives you what you're looking for in an ideal world. So, you know, why now? I mean, it really is now because we have the technology, we have the modalities, and we have the vision on how to utilize this in a lower cost and high quality treatment way. So the history is circular. We're now, in some sense, going back to how things started when people didn't have enough money to buy a gantry, but we're actually doing it in a way that's much better than people who actually have a gantry. So I think now's the time. Why isn't every company in the world doing that? Because they don't have the vision and they're stuck in that rut.
Yeah, and I just want to add, Jay, thank you for that. I just want to add that this is actually the first time it's done in this direction. You know, before we added upright and chair solutions to systems that were designed for for supine treatments. But here we said, let's design something that will work for all modalities, and then we can add any beam to it. So we're actually starting in the opposite direction than was done traditionally. Right? Mark, maybe you can you can mention about the one-legged or three-legged chair, right?
Yeah, I was just going to come in. You know, the limitations of our chair are really because we had a treatment room and we had to design a treatment chair around that treatment room. I think what Leo's really working on here is building the ideal chair that can treat all sites. Put the right imaging systems around that we need: volumetric, KV, particle imaging, even PET, or all of those around the system, and then put in the nozzle. I think that's the right way to do it, and that's why we have the limitations we have, because we had to go backwards because of what the cards that were dealt to us.
Yeah, the flexibility is key, Mark. So we have got some questions here from the audience. So I'll just pick up one of these and then we can see who wants to take this. So the question says, great presentation. Some physicians have expressed concern that the vast majority of patients today are treated in a traditional supine position. This means you should duplicate imaging to use the upright patient positioning system full potential. Have you identified any of these concerns? What's your opinion? Maybe Mark, might be the best person to answer that one, being as you're doing the long treatment.
All stuck in a rut.
Yeah. Well, I think some of the things that we did to hopefully push success was was to try to reference back to things that the physicians were comfortable with, and maybe Dr. Welsh can say this. Of course, one thing is when if you take the CTs and you pitch them, ours is pitched up 70 degrees, not 90. If you pitch it up 70 degrees and reconstruct those images, they look awful. The axials look like these weird coronals, and they're very, very confusing to see. So with that in mind, though, now with the registration tools that we have, we would never hand the physicians an awkward CT scan like that to and try to contour on it. I think that's just not fair. So the good thing is the images actually are acquired in the traditional kind of axial type sense, and then all of the weird stuff, the rotations, happen in the treatment planning side. So that's done. There's a couple treatment planning systems that can handle a 70-degree pitch, so they just do it all. They keep the axial images and then just rotate the beams up. And then other ones don't, and they're working on it. I think that some of the vendors, like I know RayStation's working very hard to allow these seated treatments. They're allowing to do the same thing, but right now the way we get around it is we actually take the images and rotate them up and plan on the rotated up images. But I think that's something that will be solved in the near future. So we're not really duplicating any imaging at all. I think that some of the registrations of like a PET or an MRI, we still have that same problem of that the anatomy isn't exactly the same. So image registrations tools are able to handle those. So we don't really have any troubles with that. And no complaints from the physician, at least on the contouring side.
Jim, any thoughts from your side on that?
Sure, I could just add to what Mark has just said and reinforce it. But in case it wasn't clear, I want to emphasize that we do take a CT simulation of the patients in that upright position using the horizontally mounted CT scanner. So in that sense, there is this extra or different CT simulation. But like Mark just said, everything else is pretty much identical.
Perfect. Thank you, guys. And then another question that we've got here, are image guidance devices for particle beam range verification already integrated in the system, or are you still working on including them? I think there's a couple of people that could answer this one from our side. Who wants to take that?
I could start by saying that along with Mark and others, this has been my research effort for the last several years, proton CT, proton radiography, in an effort to minimize range uncertainty. And part of my enthusiasm for all of this approach that we're talking about today is above and beyond the clinical advantages. Specifically, it's because when you think about it, proton CT is something that would be quite natural to obtain with a proton radiography system by rotating the patient at a gentle rate in comparison to the efforts that would be technologically daunting if we were trying to obtain proton CT from a gantry. So that's one solution for the range uncertainty issue that we're trying to integrate into the system right now.
Yeah, and I think certainly from our perspective, we think it's, with proton therapy, especially if you look at it, the beam and the proton beam and the work of so many people like Jay have really got the proton beam to the point where not many people say, oh, we need huge advances on the beam, but it's really how do we bring the image guidance into the room so that we can really make the best use of that short bright peak. So having the fixed beam and removing the need for a gantry really does allow you to bring so much more to the table or to the chair, in fact, when it comes to image guidance. So I think it's it's a really exciting field to be in, looking at bringing that image guidance, importantly, to the ISA center. And yeah, I think that's exactly right, Jim. We've got another really interesting one here. Someone said, do you expect the sweet spot of the indications for using this couch for upright radiation therapy to be further reduced with the addition of the Leo Cancer Care CT ring? So I'm interpreting that as saying, well, if we're looking at upright radiation therapy and there are some potential limitations to where we can use it, what do people think about reducing those limitations, and how do we think that the upright CT, especially that diagnostic quality CT, will really help?
I could take a first stab at this because maybe I'm misinterpreting the question. The upright CT would be in a different part of the room or in a different room altogether potentially, and therefore not interfering in any way with the treatment delivery. So that's the way it is in with Mark's setup with the P-Cure chair. The upright treatment chair, the P-Cure chair, is in the same room as the horizontally mounted CT, but they're in separate parts of the room and don't physically interfere with one another. So whatever you see on the CT scan is something that you can deliver treatment to in the chair, the same chair. It just moves from one place to another under the horizontally mounted CT and then over here to the treatment beam. But they're not going to physically interfere with each other, if that was what the question was.
I think the question, as I interpret it, is more around, if you put an upright patient positioning system at the ISA center, there may be some limitations to using upright patient positioning, which is kind of one question itself. But then if you are able to, as the Leo Cancer Care system does, it mounts the CT at ISA center so that you can get the diagnostic quality imaging at ISA center. Having that high quality imaging, what do you guys think about the importance and the necessity for that high quality imaging within the treatment room?
Well, for the targets that where we're seeing, we've kind of just been talking big benefits. So lung and head and neck, those patients require a lot, adaptive therapy all the time for protons. It's really high. So having, planning quality imaging at the ISA center in the treatment position will be a huge jump into the adaptive planning solution in the future.
Perfect. No, I think that's, I think that's exactly right. And another question that we've got here, maybe this one to you, Lawrence. Please expand upon the impact of improved patient experience using upright treatment on the patient's care and ultimately medical success, as well as the patient as a consumer to choose a treatment center focused on a better patient experience. And I think, that's something that we necessarily don't always make the link strong enough. We don't consider necessarily enough the benefit between patient comfort and clinical outcomes. But Lawrence, what is your thought there?
Yeah, so we did a survey, we did a study, well, a very small study, but with patients where we asked them to sit in the chair, and this is when we did the interfraction variability study. But we had a little survey where we asked about things like, how easy was it to get on the chair compared to getting on a couch? How did you feel? Did you feel safe? Did you feel calm? How was your arm position? Things like that. And that was with our early version of our chair, which, you know, essentially looked like we built it in our garage, because we sort of had. And, you know, so it wasn't a device that when you looked at it gave you a lot of confidence, but they sat on it and we got very similar responses for the two devices. There was a bit of a preference for the chair for the arms, for reasons that I was talking about earlier. But other than that, we got very similar responses. But that was with patients who were very early in their treatment before they were feeling sicker. So I really think that the patient experience is going to be better with the chairs, you know, independent of whether it's better clinically. I think just the experience, once you've got a properly designed chair that fills you with a bit more confidence than our garage version, I think it's definitely gonna, you know, people are gonna feel good about that. And probably Mark and Jim have, you know, you've actually been sitting people on a regular basis, so you probably have more to say about that.
You know, we haven't used it as like as much of a marketing thing at all, or you know, it's actually a tool. You know, we do look at CTs. You know, CTs. If we have too much motion, say on a you know, on a supine scan, we'll CT the patient seated and see if we can reduce the motion, which works sometimes very well. So so we haven't used it as more of like a patient experience thing, more of just as a clinical tool. Maybe we're missing out on something there, but we haven't had that opportunity yet.
Steve, there was one question that was missed further up, if you go back, just to be thorough.
Yeah, there's a few, and any questions that we don't, just in the interest of time, any questions we don't get to, we'll make sure that we follow up with afterwards. Which one were you thinking, Rob?
There was a question about the use of nanoparticles in flash.
I don't see any reason to believe
Here.
That there would be a big difference between the upright position and the supine position, but I don't have any data on that to confirm or refute my assertion.
Yeah, I think the important thing there is to be able to get imaging at the real time to make sure the patient's in the correct position for flash, since you'll probably only be delivering one pulse of radiation, or most two or three. Almost going back to the earlier days of conformal radiation therapy. And so I think it's important that those beams are hitting the target you think they're hitting. So I think things like proton radiography, you know, prompt PET, and prompt gamma will be important for that as well as even cone beam CT, real-time fluoro-based systems will be important.
Yeah, I think the more dose you want to deliver in a shorter period of time, the more important it becomes to improve your image guidance. And I think, you know, that's we're definitely going to see that with flash. So unfortunately, we have come to the end of the time. As I said, all of the questions that we didn't get through here, we will follow up with you all afterwards. We've got the names next to each of them, and we'll collect the thoughts of our scientific advisory board and get back to you with an answer to those questions. I'll finish up by just thanking everybody for joining us today, and also thanking our scientific advisory board for joining and sharing their views and opinions, their experiences. I think personally, from our perspective, we're all incredibly excited to be delivering such innovative upright radiation therapy technology to the market. And I hope from the discussion that we've had today, you can all see the huge potential and huge benefits that are available through upright patient positioning. So thank you very much again to everybody for joining, and we will share this presentation with you afterwards as well.